Hi everyone, welcome to our week 12 lecture on Let's Talk About Death and Dying. So, palliative care at the end of life. What are the goals of palliative care? Well, some of the top goals are to provide relief from symptoms, including pain. Really important to regard dying as a normal process, normal end-of-life process, affirm life and neither hasten nor postpone life. The ability to support holistic client care and enhance quality of life, to offer support to clients to live as actively as possible until death, and then offering support to the family during the client's illness and in their own bereavement. So goals for palliative care and things to think about when you're advocating for good palliative care. So what are some of the challenges of care? Well, you may have your own personal anxieties of coping with and caring for families and patients during end-of-life care. There may be a sense of uncertainty, a lack of experience, maybe that for some, death is a failure and it's not a natural progression of life. It may be seen as the enemy. The socialization of death with respect to your own cultural differences and the patients that you're dealing with and their cultural differences. Not having all the answers, and you won't have all the answers, and the family responses are different based on each specific situation. Is it something that has been drastic and very short notice? Or is it something that families have been able to plan towards? And so the family responses are going to be all different. And those are some of the big challenges of providing care at end of life. So dying with dignity, it's all about the fact that you as a nurse are going to be experiencing dying with an individual, and it's very much a mutually suffering experience. You think of things such as, what should I say? What should I do? And the importance of reflecting and clarifying your own values and beliefs before engaging with the client and family. So when you're thinking about preparing for death, remember it's all about the life and the choice of the individual that you're working with. And if we think of Parsi, we think that a person's lived out their experiences based on their own personal values. And the choice involves that continuous change processes. And as you go through life, you're constantly making choices and changing them as your life goes on. And I think one of the hardest parts is that there's no standards of normality, is that there's no normal when it comes to dying. Everyone is different. And it may not be what we believe in, but our nursing focus is the quality of life for that individual. And we are not here to judge, but we're here to support and advocate for that specific client. And so no standards of normality, and it's based again on client choice. What is their quality of life? So end-of-life care is all about providing comfort and supportive care during the dying process to improve the quality of remaining life and help ensure a dignified death. And this is from it's from what you would typically think of from our nursing values, but it's from an article called Quality End-of-Life Care, the Right of Every Canadian. So what is a good death? Well, the importance about not prolonging death. And that is going to be a struggle that you and your collaborative team may have with the family about death is imminent and we can't prolong this death. It's about strengthening those relationships with loved one and having that good mutual respect for each other, advocating for the client. Again, your role though is to advocate for the client and not for the family, but bringing forward those family concerns that they may have about their loved one is very important. Relieving the burden for their loved ones, receiving adequate pain and symptom management, and achieving a sense of control for the patient. And how will you do that to make sure that that patient's in control of their actual death? So if we look at the definitions of death, death is a permanent loss of capacity for consciousness and all brainstem functions. It's the irreversible cessation of all functions of the entire brain, including the brainstem, and it occurs when all vital organs and systems cease to function. So when we're thinking about the physical manifestations of a client approaching death, what do we think about? And so as death approaches, there's a declining oxygenation, there's a change in sensory input, and there's also a lot of metabolic changes that happen. So with sensory, remember that hearing is the last sense to disappear. So really important that patients and clients can hear you. Touch, they have a decreased sensation, a decreased perception of pain and touch. The taste and smell is decreased, and their vision becomes blurry. There may be a sinking or a glazing of eyes, an absent blink reflex. Eyelids might remain half open. Their skin could be mottling of the hands, feet, arms, and legs. Cold, clammy skin. Cyanosis of the nose and the nail beds and the knees. A wax-like skin very near to death. Respiratory, you can have an increased respiratory rate. Common is changed Stokes respirations where there's periods of apnea. Inability to cough and clear secretions, and that's what we call that death rattle. And irregular breathing, gradually slowing to terminal gasps of air. And then the urinary system will gradually decrease. You'll have incontinence and anorexia, so the absence of urine. Other physical manifestations are your GI system. So the slowing of digestive and impossibility of cessation of the digestive tract altogether. Accumulation of gas, distension and nausea, loss of sphincter control, so incontinence. Bowel movements may occur when death is imminent or at the time of death. MSK, gradual loss of ability to move. A sagging of the jaw due to loss of facial muscle tone, difficulty speaking and swallowing, difficulty maintaining posture, body posture and alignment, loss of gag reflex, and myoclonus jerking in patients is seen in patients with large amounts of opioids, so narcotics on board. And then your cardiovascular system, increased heart rate with later the heart rate slowing and weakening. Irregular rhythm, decreased blood pressure, delayed absorption of drugs, drugs that are given IM or subcutaneously. And then the psychological or the psychosocial manifestations, altered decision-making, anxiety about unfinished business and needing to finish things, decreased socialization, fear of loneliness, meaningless, fear of pain, helplessness. These are some of the clients' anxieties that they will have. Other individuals will do a life review. They may have a sense of peacefulness. They may be restless. They're wanting to say goodbye. Maybe some unusual communication, having vision-like experiences, or maybe the individual may become withdrawn. So your physical care. So your nursing assessment and care, if we're thinking neurological, we're going to be assessing the level of consciousness, presence of reflexes, your pupil responses. Circulation, looking at vital signs, skin color and temperature. Respiratory, the character and the patterns of respirations, the characteristics of breath sounds, are they wet sounding? GI, nutritional and fluid intake, bowel functioning. Renals, looking at your urine output, and the skin. The skin becomes fragile and breaks down very easily. And then other physical care, pain. So pain can be acute or chronic, and physical and emotional irritations may exacerbate. And there's sources of fear. And so the treatment is assessment, minimize the irritations, giving pain medication on a regular schedule, do not delay. Maybe some alternative treatments, always reassessing the effectiveness of it. Delirium. And so remember, delirium is characterized by confusion or the clouding of consciousness, incoherence, fear, anxiety. There's often hallucinations. And the causes could be, narcotics, steroids, underlying disease process, and it's generally considered reversible in some circumstances, but it may be misidentified as depression, psychosis, anger, or anxiety. And then the treatment again is those reversible causes for pain, constipation, maybe urinary retention, having a quiet, well-lit room, reorientate the client frequently, provide reassurance, touch, having the family present, maybe use of benzodiazepines if they're anxious, sedatives and antipsychotics. It's really common to have a pooling of secretions. And so you may be doing gentle oropharyngeal suctioning. You can give medications to decrease the amount of secretions, which is often given in palliative care. Weakness and fatigue is very important. To think about your timing of your nursing interventions. Assist as needed and complete any valued or desired activities, support aids for positioning, frequent rest periods. Myoclonus, if distressing, it may lead to having a modified drug plan. Changes in opioid use may decrease myoclonus. Skin breakdown, assess frequently, perform wound care diligently. Pressure relieving mattresses, prevent the shearing effects. So using proper transfer techniques, preventative strategies for skin irritation from bowel and bladder incontinence. Bowel patterns, so assess and monitor for fecal impaction, encourage mobility as tolerated, having a high fiber diet, fluids, and the use of enemas, suppositories, and laxatives as required. Urinary continence, using absorbent pads, indwelling catheters, or external catheters should be considered. Having an appropriate routine for incontinent care, and anorexia, nausea, and vomiting. So assess for complaints and the source of the stimulus. Have family bring in their favorite meals or culturally appropriate meals, offering smaller, more frequent meals. Consider drug modifications, administer antiemetics as required before meals, and frequent mouth care is really important. And then for psychological care, if we're thinking of anxiety and depression, these are common manifestations. And so thinking about, what's happening, fear, pain, altered physiological states, drugs used in high doses. So you want to encourage, support, and educate. That may alleviate anxiety. And the use of both pharmacological and non-pharmacological methods, such as guided imagery or massage. So a lot of fear comes from three sources. Pain, so the fear of pain, fear of loneliness and abandonment, and fear of meaninglessness. And so individuals may examine previous actions and have regrets. They'll go through a life review, and that may be a positive thing, or it may be very anxiety provoking. Grief, and so thinking about goals for grief resolution, and including allowing the client to express those feelings related to grief. And so maybe having a social worker involved or a chaplain involved. They may feel anger, and anger is a normal response. So you cannot force acceptance of the loss, and nurses are sometimes the target of anger, and it can be taken personally, and so don't take that personally. And so as death approaches, you need to think about thinking about all these strategies for the family and also for the nurse. And then hopelessness and powerlessness, those anxieties that they feel from those areas as well, those psychological areas. So, and not to forget culturally congruent care. And remember that death and end-of-life care is defined by personal and cultural values. And so it's important in many cultures, the acknowledgement of friends and families. There's different spiritual and religious practices and rituals. There's many influential decisions that come from different cultures relating autopsy and organ donation. And then all funeral rites is a really interesting and important thing to consider with families at end-of-life care. And then looking at some of the legal and ethical issues affecting this time of individuals' lives. And so clients and families struggle with many decisions during a terminal illness, such as whether or not to do CPR, whether or not to have admission to an intensive care unit. And then family care, thinking about what families want. And from the research, families want the patient to be treated and themselves and their friends with care, dignity, and compassion. And they want caregivers to demonstrate caring attitudes and behavior and to provide the information and education that they need. Families want symptom management. They'll need emotional support, including spiritual and religious support. And provider responsiveness and consistency of care is really important from the healthcare provider. And then moving into advanced directives. So the legal documents that are used in end-of-life care. And these are written documents prepared by a competent person outlining their treatment wishes should they become incapacitated. And these are such things as advanced directives. And these are instructional directives such as living wills or treatment directives. Other legal documents are a power of attorney for personal care, and an individual may have a proxy directive. And again, these are a power of attorney, and it lists the person or persons who will be making healthcare decisions should the client become unable to make those informed decisions for themselves. And these individuals may be called a substitute decision maker, an agent, or a proxy. Other legal documents could be a do not resuscitate order. And so again, that's an order instructing healthcare providers not to attempt CPR. Oftentimes it's requested by family, but it's always remember that do not resuscitate does not mean do not treat. And so it doesn't preclude the use of other forms of treatment or care. And this kind of goes into looking at do not resuscitate. We're looking at whether it's going to be a full code or not, we call it. Or other areas are looking at allowing a natural death, withholding or withdrawing treatments. And so these are all different language behind different documents at the end of life care. And again, all of these need a healthcare provider order. And then medical assistance in dying. This has really changed in the last 6 months. So if we look at the trajectory in Canada, MAID became legal in Canada in June of 2016 by passing Bill C-14. In May 2017, some updates were made to it to just provide some more clarity. In November of 2018, federal regulations were put in place to plan for better monitoring and reporting requirements. And then something that's really changed in March of 2021 is Bill 17 was passed, and it's an act to amend the criminal code. And in a nutshell, what it's done is expand the eligibility to include persons whose natural death is not reasonably foreseeable, and it also includes many safeguards with respect to these new eligibility criteria. So really important for nurses to understand the new Bill C-17. C7. And then palliative sedation. This is something that's been passed in many hospitals with palliative care. And it is the intentionality of providing sedation to people in order to relieve symptoms in the last days of a client's life. And it kind of goes against, or is kind of part of this principle of double effect. And it's justifying the use of medications that cause sedation as an adverse effect or an unintended harm as its primary role to relieve suffering that are not intended to hasten death. So it's very important when physicians are ordering palliative sedation that it is really used to not cause harm, but it's used to relieve suffering. And it's not intended to hasten or bring along someone's death quicker. And so this came about because of the misunderstanding of the use of opioids at the end of life. And it was also brought about by many clients do not receive adequate medication at the end of life, which may lead to physical and emotional suffering from uncontrolled pain and symptoms. And terminally ill clients should not be concerned with physical dependence when the goal of treatment is comfort until death. You're not going to be someone who's terminally ill, you should not be concerned about their addiction or their physical dependence on drugs or sedation. And then organ and tissue donation. So all persons who are 16 years of age or older and are competent may choose organ and tissue donation. Only clients who have sustained a non-recoverable injury and are on life support may donate organs. All clients have the potential to donate tissue, and it absolutely needs to be on the client's medical record. Pronouncement of death. In many jurisdictions and agencies, registered nurses are legally able to pronounce death. Now, pronouncing death differs significantly from certification of death. So, pronouncement of death means that you have determined that life has ceased based on a physical assessment, whereas a certification of death is the legally required completion of a death certificate stating the cause of death. And it can only be undertaken by a physician, and now a nurse practitioner can do it, or a coroner. So that's the difference between the two. And lastly, what about you, the nurse, caring for the nurse? So many nurses who care for dying clients do so because they passionately care about providing high quality end-of-life care. And no doubt, caring for dying clients is intense and really emotionally charging. And so you need to be aware of how grief affects them personally, affects you personally, and you need to not shove those feelings aside. You are not immune to feelings of loss. And it's really important to acknowledge those feelings. And it's very common for nurses to feel helpless and powerless when dealing with death. You may feel feelings of sorrow, guilt, frustration, and those need to be expressed. So really recognize and acknowledge what you can and cannot control. Recognize the personal feelings that you have to allow openness. And it's okay to cry with a client or family during the grieving process. That is okay. And so, if you're working in areas where there is a high rates of death, you need to think of interventions that focus on your own personal needs that alleviate the stress. So thinking about those hobbies or other interests, scheduling time for oneself, maintaining a peer support system, developing a support system beyond the workplace. This is really important. And lastly, there are many organizations, especially specialized hospice palliative care teams, that can help nurses cope. And so if you're feeling in a situation that you are not dealing well with how to cope with death and dying, I would definitely encourage you to reach out to these hospice or palliative care teams for more support.